Good morning, everybody. Welcome to day 2, session 3 of the 14 Days to Paramedic Immersion Experience. I am your host, Coach Joshua. So good to be with everybody again. So let's welcome everybody that's coming in. For those of you who are new, for those of you who are catching it in the replay, welcome. We do have some new people today. Let's see if you can get those cameras on so I can see those smiling faces. And let's see if we could have Darius. Darius, you want to introduce yourself? You're new?
Yeah, name's Darius Anderson. I work here in Jacksonville, Florida. Been a firefighter for about 8 years now. And I finished paramedic school a year ago, and I'm just trying to pass my NREMT.
All right, well, we got you, man. That's what we're here for. Every day, we're just going to be building on the story. All right, so if you can go back and mute yourself. Let's see. Caleb, good morning. Lucian, good morning. Tammy, Jeff, good morning, everybody. So,
morning.
What I want to say, good morning. So what I want to say to everybody is if you haven't watched the replays from Tuesday sessions, the morning and evening session, make sure you're watching those. Make sure you're staying on top of those replays because every day the story continues to build. Now, just for the benefit of, since we have new people today, we're going to review a few things that we've covered from the first 2 sessions, but then we just keep the story moving. So any questions about anything that we covered so far? All right, any questions about anything? Okay, so what I want you to do is, as we're going through the information today, don't worry so much about trying to take all the notes down because you have access to the replays, okay? You're going to have access to the replays the whole time for these 2 weeks, especially this weekend coming up. I know it's Super Bowl weekend, but you're going to have time over the weekend to, or make time at least, to make sure you're going through the replays. Now, as this course is designed, it's kind of 2 parts. So even though you get access to 3 courses, don't worry about the EKG Mastery Challenge for now. That's more for after you pass. You have lifetime access to that, so you're going to be able to go back into that at any point. But for this course, for these 2 weeks, I want you to really lock in with me. Basically, it's 2 parts, okay? How many parts did I say? Talk back to me. All right, so we got 2 parts essentially. One part is what we're doing right now. This is the live, this is the 14-day. So in your portal, it's listed as the 14-day course, the 14 Days to Paramedic Immersion Experience. That's one thing. So all of our live sessions and all the replays from the live sessions, that's all going to be in your 14-day course. But you also have a companion course that kind of goes with it. And that's basically where I'm teaching you on video the content that you need to really master for the National Registry. And that's in the NREMT Pass Self-Study course. So when we're here today or when we're catching the replay, that's the 14-day stuff. But then the rest of your time, you want to be pouring into that the NREMT Pass course, because I don't have the time in this session to go over all of that information. And that's where I taught for 5 days during a live challenge. And so you're going to have that. All right, so let's just jump right into it. All right, everybody, as you're coming in, make sure you turn on your camera so I'll be able to see you. That also helps me to kind of look at you, look at your face, look at your facial expression to make sure that you're locking in with me so that I can understand if you're actually understanding the material. All right, so we're just going to jump right into it. So as people are coming on, good morning, everybody, but let's get to work. So, and for those of you who are new, like I said, well, in fact, we'll actually just jump right into it now. Let me just add a page here. Oh, okay. Put it in the wrong spot, but that's okay. So for those of you who are new, let me just kind of quickly go over this. There are 2 big things I want to cover. One of them is 5 steps to taking a test. This will be a good review for everybody, though. When it comes to taking a test, our 5-step process that we're going to use, okay? Or actually, you guys tell me. So let's see. Who do we have? So who's already been here? Marshall, you've been here. Tell us our 5 steps to taking a test. So whether we have a long paragraph or whether we just have like a 1-line question. All right, so there are 5 steps. What's step number 1? I know this is review, but we got to use this information in a few minutes. Okay, what's
Starting with the question first.
Okay, let me turn you down a little in here. Okay, so start with the question first. So read the question, the actual question. So in the long paragraph, so you got all these words here. You got all this stuff, but the actual question is this part right here. Okay? Or if it's just a one-line question, then that's the actual question. So step number 1 is read the question. What's step number 2?
Read the paragraph.
Somebody else say it again.
Is it a one-step or a two-step question?
Gotcha. Okay.
Right.
So it's going to be either a one-step or a two-step. Now, for those of you who weren't here, let's explain what that is. So number 2 for taking a test is this a one-step question or is this a two-step question? Okay. What's the difference? A one-step question is where all you need, like basically, it's kind of like this. Imagine taking a one-step question. Hold on. Let me do something real quick. Let's fill and blank. Imagine if I covered up the whole paragraph. A one-step question is where all you need to know to answer the question is the question itself. Nothing up here in this story makes a difference at all. That's a one-step question. If that's the case, we're literally just going to go, we're going to come up with the answer in our head, and then we go find our answer. And I'll tell you that in just a moment. What's a two-step process? A two-step process is where you do need to know the story in order to answer the question. If it's a one-step question, we come up with the answer in our head, we go straight to the answers. We don't even read the story because nothing in the story is going to change what the answer is. It don't matter if grandma's 104, if it's a 2-year-old, if she's pregnant, if she got their head blown off, it doesn't matter. None of that changes the answer to the question. So we're not even going to waste time because the clock is ticking. We're not even going to waste time reading the question in a one-step process. Everybody good with that? Give me a thumbs up if we're good with that. Okay. Now, a two-step question is, yes, we got to read the story. Now, what's our number 3 for taking a test? Now,
analyze.
if it's a two-step, say it again.
I was going to say analyze, but read and analyze.
Okay. No, that's good. Okay. So now we're going to actually read the story, and then we're going to analyze from top to bottom. Now, when I say read, okay, let's get rid of this. So when I say read, we're not reading this like a book, okay? We're not reading this like a novel. We're actually reading just a few words at a time and analyzing it because we're going and reading for clues. There are clues in this story that should jump out to kind of paint a picture to lead us into some direction. But if you just read too fast, you're going to miss the clues, all right? So we're going to read and analyze line by line, like just a few words at a time. Now, obviously, we're looking for keywords. Every single word in this thing is not relevant. The, and, all that stuff is not necessarily relevant, but we're looking for keywords and we're analyzing what does that even mean. All right, then what's number 4? Number 4 is after you read this question, after you read the whole story, now you're going to get back to the question again, whatever the question was, and then you're going to say one more time, was this a one-step or a two-step? And the reason is because sometimes you got so lost in the story, you forgot what the actual question is. And then finally, we're going to go over to our answers. So, well, before we go to the answer choices, we answer it in our head. Okay. We automatically ask ourselves, what is the answer? And then whatever our brain tells us is the answer, that's the answer. We're going to trust it. And then what we're going to do is we're going to go over to our answer choices. Let's say we got A, B, C, D, E. We're going to go to our answer choices and we find our answer. Now, whatever answer popped up in our head, if I immediately see it, if it just immediately jumps out at me, I'm not even going to worry about starting from the bottom. I'm actually just going to pick that answer and then move to the next question. Now, you got to be careful, though, because sometimes you're looking for, like there was a key word that popped up in your head. All right, they described a situation and you're like, oh, that's DKA, that's diabetic ketoacidosis. I'm looking for ketone. So you don't want to just see the word ketone and automatically think that's the answer because this also may have the word ketone in it. So the safest thing is what we're going to do. And for those of you who are new, this may be the first time you've heard this. We're not actually going to start with letter choice A. Now, when we're reading the story, we start from top to bottom. when we're doing our answer choices, we start from bottom to top. The reason is A is most often the most common distractor. Not always, but most often when you look at all the tests that are taken in the world, A is most often the most common distractor. They put it there early because that's how most people are taught to answer questions. So if you get knocked out by a distraction early on, now you're already kind of defeated. We're going to kind of play the odds, and we're going to go the opposite way. Start at the bottom, and then we eliminate as we go. If E, we're like, nah, that's wrong. We're not going to do that. All right, D, ooh, maybe. We're going to maybe hold on to D. C, I don't know. B, nah, B is definitely wrong, and A is, nah, that's definitely wrong. Okay, now when we get down to 2 questions, we're going to say, okay, well, which one of these, number one? Now we're going to get into, if we don't know, we're going to say, all right, what's the 5-star medic method? This is just review, but this is you want to make sure we're drilling this over and over and over. Number one is there a safety concern? Yep. Number one is there any kind of safety concern that we need to address? Safety trumps everything else. Or you tell me, what's number 2?
Sick or not sick?
Yeah, sick or not sick. Now, how do we recognize sick? What's our number 1 telltale sign of sick?
Altered mental status.
Altered mental status. Okay, I'll tell you why in just a moment. Well, I've already mentioned it, but for the benefit of those who are new. All right, sick or not sick. If they're sick, what the question is pointing to is you need to do something. There's some kind of treatment that needs to be done versus something that doesn't need to be done. All right, sick, we got to do something. Not sick, we're probably not going to do anything. That's why you want to kind of organize it this way, sick or not sick, because, okay, sick, we do stuff. Not sick, okay, we're probably going to monitor. We probably just observe things like that. Now, what's our number 3 of the star?
Stable, not stable.
Ooh, stable or unstable, okay. All right, now, definitely if they're in any sign of shock, for sure they're going to be unstable. Now, our signs of shock, obviously, altered mental status is going to be number 1. Then we're going to have increased heart rate with symptoms, increased respiratory rate with symptoms, not just that the heart rate is fast, not just that the breathing rate is fast, is that they also have symptoms. I know I'm speeding along. It's just that we've covered all of this already, and this is mainly just review. What's number 4 of the star?
Fix or support.
Okay, good. Okay, fix or support. Now, obviously, so we've already kind of answered our questions. Let's see if I can shrink it down a little. Okay, so first question was, is there a safety concern? If there's a safety concern, that's like the BSI stuff. BSI, scene safety, mechanism of injury, nature of illness, number of patients, resources, all of that stuff that's in bucket number 1. For those of you who don't know what I'm talking about, you're going to see this every day of the NREMT pass course. That's in bucket number 1. All of that stuff points to safety. If there's a safety concern, it don't matter what's going on with the patient. We have to address the safety concern first. Sometimes the safety is we need to retreat. We don't need to be there. We need to get somebody else to manage the scene. Sometimes it's we need to get a hazmat team. We need to call law enforcement. We need to get a helicopter. All of those are safety related things. But if there's a safety concern, nothing else gets done until we address safety. Everybody good with that? Now, so we've addressed, is there a safety concern? Are they sick or not sick? Okay, yes, they're sick. Okay, now are they stable or unstable? Oh, they're sick and unstable. Okay, sick says we need to fix something. Okay, just the fact that they're sick means we fix something. If they're unstable, that means we fix it now. Okay, what that means is we need to treat life threats. So unstable means that we treat life threats, and then it's rapid transport. That's rapid. Okay, life threats, then rapid transport. I'm just showing you a way to organize the information in your head so that you don't get overwhelmed. We're just going to follow a simple process, question after question after question. And this is exactly what you're going to do in real life. Well, this is what you should be doing in real life with real patients, but on your exam, this is the exact process. In fact, I don't want you deviating from this at all. Now, if let's say they're not sick, Obviously, they're stable. Now we're just going to support them. Okay. That's like, oh, give them a ride to the hospital, call a friend, stuff like that. And then what's the final point of the star?
Times, are you asking?
Oh, I just muted. I'm sorry. Say it again because I muted you. Unmute for me.
There, can you hear me now?
I can.
Are you asking for the last
Fifth
point?
point of the star. Yep.
Time sensitive.
Okay. Any time sensitive issue. All right. Give me an example of a time sensitive issue.
Be like delay in transport.
All right, taking too long. Darius, what you got?
Like a trauma situation.
Okay, major trauma. Okay, give me another one. All right,
Cardiac arrest.
Okay, cardiac arrest. Well, now cardiac arrest by itself doesn't. And this is actually something that happens a lot. Most people are just snatching up these patients in cardiac arrest, hurrying up, putting them on a stretcher, getting them to the ambulance, loading them. It's a load and go. We should, unless it's a traumatic arrest. Now, if it's, well, traumatic arrest is not cardiac arrest. So traumatic arrest is its own thing. Cardiac arrest is its own thing. Traumatic arrest obviously is a trauma-induced situation. Cardiac arrest is a medical situation. For cardiac arrest, unless there's a safety concern, you actually want to be working the patient. The guidelines suggest, the evidence supports that you want to be working the patient in the position that you find them in. So we're going to work them on we're going to work grandma on the bedroom floor. Now, obviously, if she's between the bed and a wall or something, we may have to move her, stabilizing C-spine as we move her to an open space. But we really need to be working right there because ACLS is ACLS. ACLS is the same in the hospital as it is in the pre-hospital environment. So at least for about the first 30 minutes, unless 30 minutes goes by, 20 to 30 minutes, depending on your local protocols, or if we get ROSC, we need to actually be just staying there. Okay. So cardiac arrest is not by itself a load and go situation. But STEMI, stroke, okay, all of these are time sensitive. So major trauma, STEMI, stroke, childbirth, okay, any life threat, like any major life threat. So that's going to be severe bleeding. Well, obviously, severe bleeding may be related to trauma, not always. Often it is. Seizures. Okay, so these are all time-sensitive kind of issues that, yes, in those situations, we need to kind of hurry up and initiate rapid transport, but we never just transport before taking care of immediate life threats. Immediate life threats come down to what you have learned is airway, breathing, circulation, but how I teach it is everything comes down to oxygenation. You tell me. What's the next one?
Ventilation.
Ventilation. And what's the next one?
Perfusion.
Perfusion. All right. We're on day 2 now, session 3. So this story needs to be a lot faster. Everything comes down to we got to get blood flow. So we got to get blood flow. And in that blood is what? What are the main nutrients? What's our main food in the blood?
Oxygen and glucose.
Oxygen and glucose. And where does it need to go? What's the most important organ?
Brain.
All right, most important organ is the brain. Everything comes down, and we got to get oxygen to the brain. We got to get glucose to the brain, okay? Now, that's a quick recap. We've covered this literally every session because it's the most important things that we have to know. So when in doubt, we're always going to come back to this, and you're going to see this play out in just a moment. All right, any questions so far? All right, let's go. So, okay, I think I skipped number 1. Yep, I did. So let's blow this back up. And all right. So remember our 5 steps that we're going to take a test. All right, Darius, we're gonna break you in easily. We'll give you a break, but not too long of a break. Caleb, you look like you're ready. Let's go, my man. You ready? All right. Let's see if I can get Caleb. All right, hold on. Hold on. Wait, you're cheating already. You're reading ahead. I see you. He was like, all right, what does he say? Those eyes are moving. All right, let's see if I can get Caleb on real quick. So Let's see. That's number 8. Yeah, there we go. Look at him. Handsome young man. You ready, my man?
Yeah.
All right. So we're always... Whoa, squeaky voice and everything. All right. So how are we going to start this question? Where do we start? Where do our eyes go first?
At the top and read.
What? At the top?
The question.
Where you been for the last days? Where do we start with the question, man?
Let's start
with the question. That's step 1 is to read the question, the actual question. All right. So here's the actual question. I've just circled it for you. Let's read the actual question.
Which finding most strongly indicates impending airway failure despite the normal SVO2?
All right. Now, is this going to be a 1-step or 2-step question?
2-step.
Okay. Now, so this actually could be a 1-step question. So I want to try something for a second. Now, we'll see if it works. It doesn't work all the time, but let's just try something. Let's just actually cover up the question so you don't see it. Now, just from that, I want you to see, could you answer this question? Could this be a 1-step question? So this question again, which finding most strongly indicates impending airway failure? So basically, of these answer choices, which one of them says this person is impending airway failure? Is that an oxygenation, ventilation, or perfusion problem? Airway failure. So that's respiratory failure. That's a ventilation problem. Okay. So now that we know which problem it is, remember, we got to fix the actual problem. Oxygen only fixes oxygenation problems. If it's not an oxygenation problem, oxygen isn't our first thing. So this is more of a ventilation problem. Remember, ventilation comes down to, we got to get rid of what's the gas that oxygen comes in, but what's the gas that goes out?
CO2.
Huh? CO2. And so remember this, or this is in the NREMT past. This comes up a lot. We got to get rid of all this CO2. Remember, CO2 is what makes us breathe in the first place. The chemoreceptors in the brainstem and the medulla oblongata, they detect, hey, we got all this CO2. All this CO2, why is it a problem? CO2 behaves like a what? CO2 behaves like an acid, leads to acidosis. Acidosis, why is it dangerous? This is why acidosis is a part of the trauma triad of death. The trauma triad of death, by the way, hold on, I'm coming back to acidosis. Trauma triad of death, you must know. Trauma triad of death is acidosis, coagulation, or coagulopathy, which is a problem with clotting. Either it's clotting too much or not clotting enough, but the word for that is coagulopathy. Let's just say coagulation. And then what's the last one? Anybody know? Anybody know the last point of the trauma triad of death? Huh?
Hemorrhage?
It's going to be hypothermia. Okay. You must know this. You must know the trauma triad of death. The 3 things that kill people in trauma. Number 1 is acidosis. Number 2 is coagulation or clotting problem. And then number 3 is hypothermia. This is why we don't want this patient becoming acidotic. We don't want their blood clotting prematurely or not being able to clot when it needs to clot. And this is why we have to keep all trauma patients warm. We have to turn on the heater, run it full blast, even in the summertime, because especially if there's major trauma, we're going to do our full head to toe assessment. We're going to expose them. So we're going to expose them long enough to find whatever injuries are there, but then we got to cover them back up and we got to put blankets on them and all of that. Even in the summertime, you're going to be sweating. I mean, you're dripping. Sweat is going places it don't need to go, but we got to keep this patient warm. When you get out of the ambulance, you open the doors, it's like, just some air, but we got to keep this patient warm because those are the 3 killers in trauma. Now, let's go back to this acidosis situation. Why is it so deadly in trauma? Remember, in a ventilation problem, we have excess CO2. Excess CO2 leads to CO2, carbon dioxide actually behaves like an acid. So when we have too much acid, though, that puts you in a state of acidosis. What does acidosis do? Acidosis leads to vasodilation. Vasodilation leads to shock. So the reason we have to ventilate these patients in respiratory failure is ultimately they will end up in shock. Like how I put all that together?
Mhm.
All right. So I want you to, Darius, I want you to run that story back, play it back. Tell me about the three, everything comes down to what three concepts? Everything. Let's go to Darius. Let's put him in the box for a minute. Let's go, Darius. All right, Darius, you're coming in the box. You ready?
Yeah.
Darius, let's put him in the box. He's in the box. All right. So Darius, three big concepts that everything comes down to are what?
Oxygenation, ventilation,
And
perfusion.
everything comes down to oxygenation, ventilation, perfusion, and it's all about getting blood flow to the brain.
To
All
the
right, you
brain,
got it. Now, okay, and everything it's really all about getting blood flow to the brain. Now, tell me about how do we fix oxygenation problems?
You breathe for them.
Okay, now that breathe for them is using ventilation.
Oh, okay. I see what you're doing. Okay.
So breathe for them is we're going to use a BVM. That's a bag valve mask for positive pressure ventilation. We breathe for them when there's a ventilation problem. But if it's strictly an oxygenation problem, we give them oxygen. So that's going to be O2, whether that O2 is in a nasal cannula, a non-rebreather, it could be a nebulizer, it could be a Venturi, it could be CPAP. Those are all oxygenation ways, okay? Now for ventilation, that's where we're going to use that BVM. In fact, now we never just use a BVM by itself. It's always a BVM plus an airway adjunct. So let's just say adjunct plus oxygen. Obviously, we don't do a BVM by itself. There's always high flow oxygen flowing through the BVM. All right, now, in respiratory failure, though, that's what this question was asking. In respiratory failure, that's a ventilation problem where you're not blowing off the CO2. You're retaining too much CO2. When you retain too much CO2, pick it up from there. That leads to?
Acidosis.
Acidosis. Acidosis leads to?
Shock. I'm sorry, vasodilation.
Don't be skipping steps. Acidosis leads to vasodilation. We're going to make the pipes bigger. We're going to open up we're going to widen out those blood vessels, and then that's going to tank the blood pressure and lead them to shock. Run it back again. Give me that story again.
So oxygen, perfusion, ventilation. Those are the most important.
Okay, everything comes down to oxygenation. All right, I want you guys to hear me say the story, and then I want you to be practicing. You need to be saying this every day. Everything comes down to oxygenation, ventilation, perfusion. Everything is about getting oxygen and glucose to the brain. We fix oxygenation problems with oxygen. We fix ventilation problems with a BVM. The reason we don't want in a ventilatory problem, we have excess CO2. Excess CO2 leads to acidosis. Acidosis leads to vasodilation. Vasodilation leads to shock. Run it back.
All right. Well, all right.
It's on the screen.
Yeah. So oxygenation, ventilation, and perfusion, those are the most important things to perfuse the brain.
Okay.
You don't want the patient to become acidotic or have acidosis, because if they have acidosis, then that leads to vasodilation, and vasodilation leads to shock.
Okay, and what was the first trigger for the acidosis? What do we have too much of?
Too much CO2.
Too much CO2. Okay, I want everybody to know this story cold. All right, good.
All right.
Now let's keep going. All right, good job. So, well, since you're there, let's just keep you there and go back to this question. So this question was, which finding most strongly indicates impending airway failure? So basically, this is a ventilatory problem. Which one of these points to a ventilation problem? Anything? Let's start with D.
Absence of wheezes on auscultation.
That says absence of wheezes on auscultation. So basically, this is saying you don't hear any wheezing.
Oh, that's not the answer.
Okay, he was confident on that. Okay, now what about C?
I think C is the answer, because the inability to speak full sentences, that sounds to me like a ventilation problem.
Oh, man, okay. You don't even need me. How about you just take over? Okay, all right. He likes that. Let's go to B. Let's go to B.
Hypertension and tachycardia, that doesn't have anything to do with
Go. Keep going.
airway failure.
Hypertension and tachycardia deals with which one of those problems?
Shock.
Okay, which is is shock a oxygenation problem, a ventilation problem, or a perfusion problem?
It's a perfusion problem.
What? So in fact, the definition of shock, what is shock? Shock equals inadequate or hypo perfusion. So of course shock is a perfusion problem, but check this out. So this question, so hypertension is dealing with blood pressure. Blood pressure is a part of our equation. So this, I've already covered this, but blood pressure is heart rate times stroke volume times systemic vascular resistance. All of that is a measure of perfusion. So hypertension that's blood pressure, that's perfusion. Tachycardia is heart rate, that's related to perfusion. So just see why I say knowing oxygenation, ventilation, perfusion helps you out of a lot of situations, because this question says airway failure. Airway failure comes down, everything has to be one of three problems. It's got to be an oxygenation problem, a ventilation problem, or a perfusion problem. If you'll just organize the information in this triangle, this is going to quickly help you identify, like, what box are we even in? Like, what side of the triangle are we in? Airway failure is a ventilation problem, so we're looking for answers that deal with ventilation. Because this deals with perfusion, this deals with perfusion. Neither one of those are ventilation. That's automatically wrong. And then what about a respiratory rate of 30?
That's a possibility, but
okay, now all right, that's why I put it there.
Yeah.
So a respiratory rate of but remember I said A is most often the distractor.
Throw you off.
Okay.
Right.
I purposely put it there as a distractor because yes, a respiratory rate of 30. Now, respiratory rate of 30 is kind of borderline. So we actually say a ventilation problem. So let's give me a little room here. So if our normal breathing rate is 12 to 20 for an adult, we say, so 10 and 30 are our like cutoffs. So it's really, we say less than 10 and greater than 30. That's where we're going to use our BVM. 30 is kind of borderline. We may still have to use a BVM, but the actual answer in this question, you're right. It is going to be C, inability to speak in full sentences. That's actually the one that most strongly indicates impending airway failure. Another way to say that is they speak in 2 to 3 words or 2 to 3 word dyspnea. Okay. Now, but notice how on this question, we actually answer the question without a story at all. How many of you would have thought that was a one-step question?
I wouldn't have.
Okay. All right. So now, like, for instance, here was the story, but we actually didn't need any of the story to answer this question. All right. So in fact, since we didn't need it, we're not even going to worry about reading the story. All right. Let's go to number 2. All right. Now, was that helpful?
Yeah.
Okay. That's only your first question with us, my man. All right, let's get Marshall. He looks like he's ready. Marshall, let's put you in the box. Marshall, take number 2.
Which action is most appropriate at this time?
1 step or 2 step?
I say it's 2 step.
All right, we got to have a story on here. So for a story, we're going to start at the top, analyzing as we go. Let's go.
A 42-year-old female is rescued from a house fire.
Whoa. We got to read it a little bit at a time because every bit may give us information or it may not. Now, 42-year-old female by itself, does that tell me anything?
Doesn't pertain to the answer.
Well, we don't know yet. But I mean, I'm saying just the fact that they told me 42-year-old female, does it automatically point to anything? No, it doesn't.
Not really. I mean,
42-year-old by itself doesn't necessarily. Now, let me tell you what could point to something.
If it was 22-year-old,
actually,
I was going to say if it's 22-year-old, then you could have a possibility OB patient, but.
Well, but actually even a 42, so I can't even say that. So we really say a female in childbearing age.
Yeah.
but childbearing age actually can go up to about 50 and a half. So we would actually, so 42, we could actually consider that as an OB. But some things that you really want to watch out for, especially if they start off 6-month-old, 2-year-old, okay? If they definitely give you the age of like a pediatric patient, especially a small, all right, we need to really like lock in here, because it may not mean anything, or it may mean something real serious. Okay, so this by itself doesn't really tell us much, not yet. So let's keep going. Keep going.
Rescue from a house fire during winter
All right,
conditions.
stop. So just stop right there. Rescue from a house fire immediately. Just like, don't worry about answer choices and stuff like that yet. House fire immediately. What am I thinking about?
Airway
Immediately.
issue.
Airway. Okay. Now, why would I have an airway issue in a house fire?
Possibly burns.
Okay, we can have
inhalation.
airway burns from. Okay, how do the burns happen? So smoke inhalation, but it's from superheated gases.
Yeah.
Those gases that get released get so hot, it's the superheated gases that cause the airway reaction. Okay. But what happens, like the smoke inhalation, how does that kill you? Why do they die from the smoke inhalation most often than even the burn itself?
From acidosis. From
Okay. Yes. I mean, we're going to get there. Yep. That is a part of it. But what's kind of the first thing that happens even before the acidosis?
CO2 inhalation.
CO2?
Carbon dioxide from the gas.
That is CO2.
Monoxide.
That is CO2.
Yeah.
Carbon dioxide is CO2.
Yeah. Carbon
Which one
monoxide.
did you mean to say? Carbon monoxide, which is CO. Okay. And little things like that could trip you up though. So CO2 or CO is carbon monoxide because there's one oxygen, and then CO2 is carbon dioxide because there are two oxygen. Okay. Okay. Carbon dioxide is what we normally have as a waste product. That's one that we breathe off, that when we have too much of, it causes acidosis that leads to CO2. Excess CO2 causes acidosis that leads to.
That's a brain fart.
Okay. CO2 causes acidosis that leads to vasodilation and shock.
Yeah.
All right, make sure you guys are saying this over and over and over, because little things like that, I'm telling you, I want you to anchor that in your head because it's going to help you a lot.
Hey, Joshua.
So, yes, sir.
I just have one question because I said you're asking what kills the patient. Was I just a few steps ahead of saying constriction, like constriction of the airways and stuff due to the inhalation?
Well, so that's all related. So that's more from those superheated gases, the body's way of trying to protect it, protect all of that stuff from going in, is it actually causes that vasoconstriction. It causes the laryngospasm. So this is kind of like a similar concept in a drowning. This is how, like, for instance, in a dry drowning where they don't actually end up having fluid in their lungs, it's where the larynx actually closes to prevent water from getting in their lungs. Same kind of concept, but it's the first thing is that you have, so it's going to be those superheated gases that come in, but the real big killer is carbon monoxide. So in this question about the house fire, what you want to be thinking is immediately carbon monoxide poisoning. Okay. How is this patient going to present with carbon monoxide poisoning? Well, as a late sign. How's their color going to be?
Colors pink.
Reddish pink.
Okay, so a lot of times they'll call it beet red or cherry red. Okay, that's kind of a late sign though. Just remember that if they have this really red appearance, like they're really, really red all over, that's probably an indication of carbon monoxide poisoning. So carbon monoxide though, why is it so deadly? So this is why we tell people don't warm up your car in the garage and stuff like that. Or if, as a responder, if you come to a scene and you got like 2 dead people, in like a confined space, you need to be thinking, oh, wait a minute, I got 2 dead people at the same time, or I got 2 unresponsive people at the same time. I need to be thinking safety, probably some kind of chemical, probably carbon monoxide. Okay. So why is it so deadly though? Because carbon monoxide. So if this is carbon monoxide, if this is a red blood cell, somebody take me from there.
It bonds to the hemoglobin.
Yeah. So
and then when you put on
remember,
the post ox, it'll show that you got 100% oxygen, but it's really carbon monoxide in the blood.
Nice. So what's happening is the hemoglobin is the protein contained within the red blood cell. But so normally we want oxygen bound to this hemoglobin, right? Normally that's what we want connected. However, in carbon monoxide, you have carbon monoxide hooking up to the seats or sitting in the seats. So all the seats are filled. All the seats have somebody in it, but it's the wrong person. We got a rogue criminal sitting in the seat. It's carbon monoxide. Okay. So yes, and it has, you'll hear textbooks refer to it. It has like 200 times greater affinity for hemoglobin than oxygen. Basically, affinity just means it loves it. Carbon monoxide loves the hemoglobin even more. And once it attaches, it's like a horrible spouse. You just can't let them go. Okay. Now go back, Marshall. Let's go back to this question. So house fire, carbon monoxide, that's what we need to be thinking of. Keep going.
She is supine.
Hold on. So just based on what I just said, carbon monoxide already, like I'm only a few words into this, and this is how my brain needs to be thinking. I saw house fire. All right. Obviously house fire during winter conditions. Okay. They're pointing to, okay, probably use a space heater, things like that, or just a fireplace. That all makes sense because they're trying to stay warm. And then now the house caught on fire. But immediately, if I analyze it that way, I'm literally 1 line into this question. What am I already thinking? Carbon monoxide poison. What's the fix for carbon monoxide poison?
Oxygen.
What?
Oxygen.
Oxygen. Yeah. Now, so already, our brain has already said oxygen. In fact, we need high flow oxygen. More specifically, we need hyperbaric oxygen. We don't have that on the ambulance, of course. We got to get them to a facility that has hyperbaric capabilities. But for us, it's oxygen. We could probably answer the question, but let's just keep reading just for education purposes. Keep reading.
She is supine on the front lawn. She is hoarse.
Okay, good. Right there. Because we need to analyze everything that we're reading. Supine on the front lawn. Good or bad?
Bad. Unless
she's just tanning, but it's in winter conditions, so she's probably not just sitting out there sunning in the wintertime. So supine on the front lawn, does that point to something serious is going on?
Yeah, she's struggling.
Okay, first of all, is there a safety concern potentially?
Yes.
Yeah, because if she got carbon monoxide poison, you could get carbon monoxide poisoning. So there may be a safety concern. If there's an answer choice that deals with safety, that's our answer. Then if not, we're going to say, is this patient sick or not sick?
She is sick.
She's supine on the front lawn. That's sick. Can we already say, is she stable or unstable?
Unstable.
She's probably unstable. And I'm only like a line and a half into the question, and I've got all that just by taking my time and analyzing it. If you just read, you're not gonna get this. You're not gonna get those answers jumping out at you like that. Now let's keep going. She's hoarse. All right. Now what does that point to?
Airway issues. Airway compromise.
Okay. Now she's having some kind of airway reaction from those superheated gases. She has soot around her mouth. What's that?
The gases.
Okay, so it's that the carbon from the carbon monoxide, the carbon itself. So sometimes you'll hear it referred to as carbonaceous sputum or soot. That's another way to say the same thing, but carbonaceous sputum or soot around her mouth and nares. Okay, she's got singed nasal hairs. All of this points to this is serious. This is an immediate airway situation. Okay, and by the way, is this an oxygenation, ventilation, or perfusion problem?
All the above.
Okay, primarily though, which one of them is it?
I say ventilation.
Okay.
Oxygenation.
It's actually an oxygenation problem because carbon monoxide is bound to the hemoglobin instead of oxygen. That's why we're given oxygen. And remember, we give oxygen for oxygenation problems. Okay, so this is actually an oxygenation problem. That's why we need to give them so much oxygen. Okay, she's alert but anxious. Okay, the fact that she's alert is at least good compared to not being alert. SpO2 is 99%. Darius already alluded to this. See, this pulse ox, does that pulse ox look good or not?
It looks good, but it's not.
It looks great, but the patient is not great at all. This can be a trick though. You look at normal vital signs and say, oh, this patient's fine. No. This patient is supine on the front lawn. She's hoarse. She's got all kind of airway concerns. We've got apparent life threats for sure. All right. And whoa, she's 99% on a non-rebreather mask. Okay, I didn't see that part. I forgot I put that.
Come
all
on,
right, lung
Josh.
sounds are clear, but yes, Joshua. Huh?
I said, come on, Joshua.
Oh, okay. And then, all right, lung sounds are clear bilaterally. Okay, that sounds good. Blood pressure. Let's analyze his blood pressure, Marshall. Hey, Tammy.
It's elevated a little bit, but I guess that'd be from compromising because of her.
Okay, I like how you said elevated versus hypertension. That's actually how you would describe that, as elevated blood pressure. Okay, so our systolic number, our top number is slightly elevated. Our bottom number is actually, we're going to say the bottom number is normal. Now, tell me about this heart rate. Compared to normal, is it normal, high, or low?
High.
Okay, so a normal heart rate, of course, for an adult is going to be 60 to 100 beats per minute. She's at 110. So, I mean, we're not dangerously concerned about that. However, but we call this, what do you call it if it's over 100? What's the word for it? All right, so it's tachycardia. And does she have symptoms? Does she have any kind of symptoms?
Horse.
Yeah. Okay. So she's tachycardia. She does have some symptoms. We're going to say she's symptomatic tachycardia. So now, because it's not just tachycardia that puts you in shock, it's tachycardia with symptoms, increased respiratory rate with symptoms. Okay. All right. And respiratory rate, 22. Is that good or bad?
Bad.
Okay. It's not, I mean, it's okay. It's not. What's a normal?
Dangerous.
What's a normal respiratory rate for an adult?
Had a brain fart again.
All right. And you gotta know these basic things. Okay, so this is going to be 12 to 20. Okay, cool. Now, based on everything we said, and we took a little longer going through the story just so I could point out some things, but basically, when I saw just this part, immediately I'm thinking, ooh, oxygenation problem from carbon monoxide. How do we fix it? We give oxygen. Now, this question says, which of these is most appropriate at this time? We already said oxygen because our brain came up with that. Let's start at D. Tell me about D.
Administer bronchodilators for airway irritation. No.
Yes or no?
No.
Because that's not oxygen. That's a medication. And by the way, we generally give oxygen before we give medications. There is an exception, and that's going to be epi. Epi was kind of like 1A, 1B. It's like oxygen, epi. They're like right there together. But that's generally the only time we're going epi. Epi is basically the medication that we'll use. It's like the one emergency thing that needs to kind of come before other things. But generally, it's going to be oxygen before we do medications. So what about C?
Prepare for early advanced airway management. Possibility.
Okay, let's hold on to it. Let's go to B.
Delay airway intervention due to adequate oxygenation. Absolutely not.
Absolutely not. I like that. And what about A?
Remove oxygen to assess on room air. Absolutely not.
Absolutely not. So we're all just by elimination, we're down to only C. So we just eliminated everything else. So C is our answer there. Now, what's our bronchodilator they're talking about? What would that be? All right, let's take you out of the box. Tammy, you coming in? All right, Marshall's like,
Coming in.
tag me out. All right, so Tammy, come on, you're coming in. Oh, I didn't put you in the box. Let's put you in the box. Okay, there you go. All right, so Tammy, what's going to be our bronchodilator they're talking about?
Could be albuterol.
Ooh, check you out. Albuterol. How does albuterol work? What's its class? Well, its class is a bronchodilator. More specifically, Caleb from the other day, more specifically, it's a short-acting beta-2 agonist bronchodilator. So a SABA. So it's short-acting, meaning that it doesn't last for a long time, but it also works quickly. So a short-acting beta-2 agonist bronchodilator. That's what albuterol is. Now, a lot of times you're going to give albuterol plus, you're going to give a dual neb, which is albuterol plus like ipratropium. And how does that work? How does the
ipratropium?
Albuterol is albuterol is the beta-2 agonist. What does that mean? So here's our lungs.
Yeah, it opens up the capillaries in the alveoli.
Okay, all right. So let's see. Well, no, that's not how I want you to say it. So what it does is it open. So I don't want you to say capillaries and alveoli because that's further down the airway and that's not where it's working. So if we take these airways, so initially we've got the trachea, and then I shouldn't have put that by the trachea. Let's not do that. Let's do it. Let's move this down. All right, so we're gonna put it like here. That's how I should have done it. Okay, so basically we have the trachea, and then we have, remember what's this little split where it goes from into the left lung versus the right lung? What's this little, the carina? All right, we never put our ET tube past the level of the carina because most often it's going to end up in the right lung just because of how it's shaped, because it's kind of a sharp angle here. So it's hard to make that turn, but it's very easy to just kind of slip off into the right lung. This is also the same reason that we put people on their left side. If we have an unresponsive patient who's choking or having a seizure, we want to put them on their left side for the same reason, so that it's harder for air to end up getting into, because otherwise, if we don't put them on their left side, it's easy for things to just slip down into the right lung and cause aspiration.
Okay.
Going back to this though, we have smooth muscle cells. That's what I have drawn in red. We have smooth muscle cells surrounding the bronchi and the bronchioles. That is what either constricts. So when we say bronchoconstriction or bronchodilation, we're talking about the smooth muscle surrounding those bronchi. What happens is the beta-2 actually binds to, so the beta-2 comes in and binds to this receptor, and that's what causes these airways to open up. Okay? This is why we use epi in breathing problems, because epi has alpha-1, beta-1, and beta-2 effects, and it's the beta-2 effect of the epi. That's why we give it in breathing emergencies like asthma, anaphylaxis, things like that, or status asthmaticus, anaphylaxis, those kind of things. Okay, so that's the albuterol, but how does the ipratropium work? So once again, albuterol is a short-acting beta-2 agonist bronchodilator that's going to dilate the smooth muscle surrounding the bronchi, open it up, so now we can get more air in. How does the ipratropium work?
I don't remember what that does.
That's
Dries
out the
okay,
mucus
so
membrane.
it is. Say it again.
Dry secretions.
Okay, who said that?
There's
There he is. Way to go, my man. All right, so that's going to be okay. It's class. It's
That's right. Dry
muscarinic.
secretions. Okay.
Yeah. Okay. It's a muscarinic antagonist, similar to like atropine. Okay, it's in the same family of atropine. This is why we give atropine in the setting of organophosphate poisoning, because it dries secretions. So ipratropium is a muscarinic antagonist that dries the secretions, because a lot of respiratory situations you end up with all this gunk in here from the inflammation. This is where the steroid comes in. Like when you're going to give that solumedrol, that 125 milligrams of solumedrol or methylprednisolone, it's for the same reason. We're going to try to calm down that inflammation and get rid of some of those secretions. But the ipratropium is to dry the secretions,
Okay.
to hopefully clear the airway, so now more oxygen comes in. And then what you're saying about the capillary, that's the part where once the oxygen comes in, now it can actually get across that capillary membrane, and then now it can get into the bloodstream. Okay? Any
Right.
questions on that? Let's go to the next one.
I have
All right,
a, I
Tammy,
have a,
since you're
I have
there,
a
you take.
question.
Yeah, let's go.
Just
What's your
I understand why the answer is like you want to obtain an air or have an advanced airway, but you were saying that you would do oxygenation before medication. And the question, just the way that I would think of it, it says that the patient was on 99 with a non-rebreather. So would they already be getting oxygen?
Yeah, but what was our
Like
correct?
I
So in this
understand why the
case,
question's right, but it was just a little confusing because technically you're already giving them oxygen. So if they're already getting oxygen, couldn't you go to medication? I understand why you would go to an advanced airway. I'm just thinking for future questions.
well, so even in this, so what medication would you give them?
Like you said, the albuterol.
Okay, so in this case, even the epi would be more beneficial than the albuterol first in terms of like what's life saving. Epi would trump albuterol. Yes, the albuterol can open up the airways, but in this case, it's not so much that we're trying to relax the airways. We're actually trying to prevent it from closing. This is why we need to be aggressive with the intubation early, because if that airway closes, we may have to end up resulting in a surgical cric. So if I got to choose between intubation and albuterol in this situation, I'm going with intubation all day. Okay, because one of them is more likely to save a life. The albuterol is less likely to save their life compared to the intubation. Does that make sense?
Yeah, and I understand why we're intubating. I was just confused on the part where, because you say if you're going to give a medication, you have to give oxygenation. And so if in the question it technically says that they're already getting oxygen, then in the answers, if there's a medication part, would you go to the medication? Not for this question.
Okay, yes. In general, then yes. Let's say it's an asthma patient and they describe the patient as wheezing. So yes, you're going to use oxygen, but then even with a nebulizer, of course, we use oxygen with a nebulizer. So it's still going to be oxygen first, right? But yes, in that situation, then we'd go with a nebulizer. By the way, how are we going to flow a nebulizer? What's our flow rate for a nebulizer treatment? Okay, so 6 to 8 liters per minute. Now, what you don't want to do is blast them away with 12, 15. So a nebulizer, we're going to go with 6 to 8. Okay, let's go with Tammy. You're on number 3. Okay. Do I need to switch? Okay, here, let's put somebody else in. That's fine. Lucian, let's put you in the box. All right, there you go. Let's go with number 3.
After BVM ventilation with supplemental oxygen, which finding most clearly indicates effective ventilation? I'm going to go with it's a one-step
or
question.
2-step. Ooh, okay. Why are you saying this is a 1-step question? You're saying you don't even need the story.
Because I should know. Yeah, I should know what indicators for a BVM would indicate I'd be using one.
Check you out. Okay. Now let me ask you, before we met, did you ever do this thing where you just don't read the story?
No.
Never been taught that. Okay. I'm telling you, this is going to help you. It's going to also pick up some time on the exam. All right. So you're saying that after BVM ventilation with supplement. So basically this is saying you give them oxygen and you're using the BVM. So after that, which says they're getting better? That's another way to say this, right? So let's go. Let's do our answers starting from the bottom.
Improved skin color.
Oh, hold on. By the way, okay. So hold on. Let me back up for a second.
Hey, Joshua.
Yes.
Hey, I'm getting a call, so I gotta get off here.
Okay. Just make sure you catch the replay.
Okay, thank you.
And I'll hopefully see you tonight.
Yeah, I'm gonna try to as long as I'm not on a call.
Yes, sir. All right, let's go. So we got oxygenation, ventilation, perfusion, right? Everything comes down to these two things or three things: oxygenation, ventilation, perfusion. This is saying, read the question.
It's already
After
telling me that
BVM
it's ventilation.
ventilation. So we're here. We're a ventilation issue. So is skin color, does that deal with ventilation?
No.
What does that deal with?
Oxygenation.
Skin
Perfusion.
color?
Perfusion.
Oh, perfusion.
Okay, so it's going to be more of perfusion. Okay. Because the reason they don't have color is they don't have blood flow.
Right.
Right. Right. So that's actually more of a perfusion issue. So I'm telling you guys, just knowing this helps you a whole lot. We already know everything comes down to this. Like literally draw it out on your exam paper, like on your little laminated thing. Draw this triangle out at the beginning when you get that tutorial section, and they give you some time to like jot down some notes. Obviously, you can't come into the exam center with notes, but after they give you the stuff, and then once the clock starts, then you can start jotting down stuff. Jot this down, and then anchor it. Like come back to this. Even if you need to jot down, okay, what are my 5 steps? Steps 1, read the question. 1 step or 2 step. Analyze from the top. 1 step or 2 step again, go to my answers, right? I would maybe jot stuff like that down. Now, improve skin color. That's a perfusion problem, so that's wrong. Now, tell me C, is it right or wrong based on oxygenation, ventilation, perfusion?
Wrong.
Why?
It's not a ventilation issue.
Okay, heart rate is a what kind of issue?
A perfusion issue.
What? Check you out. Okay, let's go to the next one.
My answer is going to be, or I would say this is it, because if you're not ventilating, your CO2 is going to go up. So decreased end tidal or decreased CO2 is going to be.
Check you out. Check you out. Okay, now, all right, I like that. But now what about A?
SpO2 increases to 99. That would be oxygenation.
Man, look how easy the question was if we just apply oxygenation, ventilation, perfusion. So boom, SpO2 measures oxygenation. That's an oxygenation issue. This question is all about ventilation. So all of our answer choices need to have something to do with ventilation. Look how easy the question becomes when we just have a framework to use. Good job. Let's go to number here. Since that was just too easy for you, go to number 4, Lucian.
Which underlying problem best explains her presentation? So it's going to be a 2-step because I don't know what her presentation is.
We got to have a story because we don't even know what's going on here. Let's
go.
go.
From the top, a 66-year-old female. So 66
Stop.
Female.
Okay. 66 female. Do they typically have a lot of problems or don't have a lot of problems medically?
From what I've seen lately, yes, they have a lot.
Okay, so 66-year-old female. Oh, so now we already know 2 of the 3 of kind of like the problems. Elderly female. The only other thing would be elderly female diabetic. Ooh, most common atypical cardiac presentation. That's the one where we have the most likely heart attacks, but they don't have chest pain. Elderly female diabetic. Okay. Right now we got elderly female. So already my alarm bells are going off. Keep going.
Complains of dizziness and nausea.
Okay. Dizziness and nausea. Do we know of a situation that could cause dizziness and nausea?
What you were just explaining?
Let's analyze. Yeah.
I
mean, I'm just asking, do we know of anything that could cause it?
There's a lot of stuff.
This. Like what?
Am I?
Ooh, okay. Heart attack. Yeah. So that'd be a perfusion issue. Okay. What else? What about a fall?
Oxygenation problem. Oh yeah, falls.
Some kind of oxygenation problem. Maybe she's got COPD or something, but that probably wouldn't cause the nausea. All right. What about maybe a migraine? Okay.
Head injury.
All right, let's keep reading. Head injury. Oh, definitely head injury. Okay. So keep going. And this is how we need to be analyzing the questions, because we need to be coming up with answers as we're reading. And then as we get more information, we're going to say, nah, it definitely is not that. So that's why we want to analyze. Keep going. She is found
seated on a couch.
Okay,
So,
that
there's
is
nothing
there anything concerning about her sitting down on the couch?
Not yet.
That's just extra information in the question. All right, keep going.
Blood pressure is 88 over 54.
Stop.
So
Good or
that's
bad?
low, bad.
Okay. So right now, what is this story pointing to? We got dizziness, we got nausea, we got, how would you call this situation? This what if you had to label this as a word, what's our word that we're going to call this situation? Give me a
Sick.
word to describe this. Okay, we can go with sick. Give me another word. Stable or unstable?
Unstable.
Ah, okay. Sick, unstable. This is all pointing to what? With this kind of blood pressure that is that low, that's pointing to what? I want one word.
Perfusion.
Okay,
Hypotension.
so it is so oxygenation, ventilation, perfusion. What'd you say?
Hypotension.
Hypotension. All right, that's the word I was looking for. We've got profound hypotension. Profound hypotension leads to
Shock.
okay. So you need to be picking up shock right away. Keep going.
Heart rate 38.
Heart
Be
rate
another
of
indicator. Heart rate of 38.
Ooh,
Be another
okay.
indicator of
Now
shock.
could this heart rate of 38 explain the dizziness?
Yes.
Sure. Okay. So now, so she's got symptoms and she's got this kind of heart rate. What when you put that combination together, what do we call that?
Symptomatic
Symptomatic what?
hypotension or symptomatic.
He's getting stressed out, guys.
It's
All right,
a
that's going to be symptomatic
shock issue.
bradycardia.
Symptomatic bradycardia.
Symptomatic
okay.
bradycardia. Okay, symptomatic bradycardia. Remember, it's signs of shock, altered mental status, increased heart rate with symptoms. It can also be decreased heart rate with symptoms, increased respiratory rate with symptoms. She's got symptoms for sure. In this case, this is a decreased heart rate with symptoms. That there again, that's more evidence for shock. Keep going. And then they
And
give us
irregular
yeah.
respiratory rate of 18.
Oh, it's heart rate of 38 and irregular. Okay, so an irregular heart rate. Okay. Respiratory rate of 18. Is that good or bad?
That's normal. It's not
Okay.
anything
Now
crazy.
but check this out. With this kind of blood pressure, her blood pressure is being low, and she's got a perfusion issue, and there's not enough oxygen and glucose going to the brain. How would I expect her respiratory rate to be?
He increased.
I would expect her respiratory rate to be fast. However, her respiratory rate is normal. That's even more concerning. It's more concerning that her respiratory rate is normal because that doesn't make sense in this situation. I expect her respiratory rate to be higher, but it's actually okay. That's even more dangerous. Make sense?
Yeah.
How many of you thought immediately that respiratory rate was dangerous? How many of you would have immediately thought that? Okay. Now, let's keep going.
SpO2 of 97.
Okay.
Skin is cool and pale.
Good or bad?
Bad.
Sick or not sick?
Sick.
Stable, unstable?
Unstable.
All of that is pointing to shock again. Okay, keep going.
She denies chest pain.
This is that, remember, the elderly female diabetic is the most common cause of, or most common presentation or atypical presentation. So she don't have chest pain, okay? We still need to do a 12 lead on this. In fact, my rule is a 12 lead, get everybody with a complaint above the belly button. Here's the belly button. Everybody with a complaint above the belly button gets a 12 lead. What does that look like? What's above the belly button? Let's cut this body in half. Abdominal pain, GI upset, just sick for no reason, chest pain, shortness of breath, okay, altered mental status, confusion, any of that gets a 12 lead, okay? So we're going to do a 12 lead here, and it shows what?
No consistent PR intervals.
All right, so immediately, so we can't, sometimes these descriptions, I did this on purpose, sometimes these descriptions can be a little misleading, because if you read this, what kind of rhythm are you thinking of right here?
with no consistent 2-hour intervals.
Yep. What kind of rhythm are you thinking?
I mean, you could think it's a block.
Okay. All right. Like what kind of block?
A third degree heart block,
Okay. Or what else?
or a second degree type
What about
1.
a secondary type 1? Okay. All right. So now, based on that, so your brain gave you second degree type 1. Now, you got to be careful here with these rhythms and these descriptions because well, here, I'll tell you in a minute. Let's go to D. Let's go to our answer choices. So this question asks, which underlying problem best explains her presentation? Now, if you
Did he just freeze for everybody else?
Yeah.
did I freeze?
Yeah.
Yes.
Oh, okay. I didn't know that. So, okay. So am I back now?
Your voice is
Yes.
calm, but your audio recording is freezing.
Okay. Sorry about that. Let's see. Let's see if I can close anything down.
The screen is blurry
All
as
right.
well.
Yeah, I can't
Okay.
make out anything on the screen.
You still can't?
No.
No, it's blurry.
Huh. Okay. Because it's perfectly fine on my end, but let me see.
Try and take him out of the box and see if that'll change anything. Nope.
All right. How about now?
No change.
Okay.
There it goes.
All right. Am I back?
It went back blurry.
Okay. So tell me if we're good. Are we good, everybody?
I mean, I can see you. It's a little blurry, but
Okay.
I can
Does the
kinda make
iPad
them-
show back up?
yes.
It's still blurry.
Okay. Okay. I'm not sure what's going on my end. It's perfectly clear, so I'm not sure what's happening there. Oh, okay. I kind of see.
It says your
I see
network
what's happening.
bandwidth is slow.
Okay. All right. So hold on. Bear with me for a second. Let me see what I can maybe close down. I got a lot of stuff going on over here. So bear with me. All right. Let's see. Most things are closed. I still got to have the studio recording. Okay. We'll see if that gets any better. Okay. I don't see what else I can close down. Here, let me close. Okay. All right. Is it any better, guys?
No, sir. There
Oh,
it goes.
yes, now.
Yes.
Okay. I didn't even do anything different, but okay. Let's keep going then. Okay. So in this case, let's go back to number 4 and let's start at the bottom.
Ventricular escape rhythm. I'm going to
But
say
the
no because
volume
it's saying
got
that the
really
heart
loud
rate
suddenly.
is irregular. And
Okay.
ventricular escape would be sinus.
Huh?
I'm just going to X that one out because it's it's saying the heart rate's irregular, and I wouldn't classify ventricular escape as an irregular heart rate.
Okay. So go to the next one.
Atrial fibrillation with slow ventricular response. I'm going to keep that one.
Okay. Let's go to B.
Second degree AV block type 1. So that'd be Winkelbach.
Okay.
We'll keep it for
Mobitz
now.
1 or Winkelbach, I'd agree. You're going to keep it. Okay. And then what about
And
the next
then
one?
just sinus bradycardia, but it wouldn't be sinus if it's irregular.
Ooh, I like that. Okay. So so now we're down to 2. So now which one of these jumps out?
Atrial fibrillation with slow ventricular response.
Okay. Tell me why you're going with that.
because it's giving me a heart rate of 38 with an irregular heart rate, and she has
I like
a
it.
complaint of
I like
dizziness.
it. Okay. So we can't jump to conclusions. So for instance, we got to see, okay, is there something in this story that supports one of these answer choices? This slow ventricular response is a slow heart rate. Is there evidence of a slow heart rate? Absolutely. She's got a heart rate of 38. So you would be correct. C would be the
Right.
answer here. Okay.
And then
All right, good.
also, I
Let's
guess
take, oh,
it
go
says
ahead.
that there's no consistent PR intervals, but with the second degree type 1, it'd be consistent, but you would just lose a beat. I guess it wouldn't be consistent. Never mind. I'm sorry, because the
It
P
actually
keeps.
wouldn't be consistent because it would be
You're right.
changing.
I was just
Now,
thinking
in second degree type 2,
it would
the
be.
PR interval stays the same. Okay.
Right.
All right. So that was good. Let's go to Tammy. Can you take the next one?
I can just be aware I'm at work, so I may have to go as well to respond to a call.
Tell them people you busy.
I wish I could. I've been trying. Okay. All right. So what does this change most likely indicate?
1 step or 2 step?
2.
All right. We got to read the story. So let's read the story.
55-year-old male, cardiac arrest. CPR in
Stop.
progress.
All right. Stop. Cardiac arrest. Sick or not sick?
Sick. Sick.
Or not? Okay. Do we need to fix something or do we need to support something? Is there a time sensitive issue? Okay. That's our 5-star medic method. Now, cardiac arrest.
I had a delay,
Is there
so I was
safety
trying to
concern?
answer.
Oh, okay. So is there a safety concern right away?
It's blurry on my end. I can't read any of that.
Okay. So it says 55-year-old male in cardiac arrest. Just that by itself, does that point to any safety concern?
No.
No, but cardiac arrest. So now there are 3 priorities in cardiac arrest. What are they? What's first priority in cardiac arrest?
Airway and compressions.
Okay, so we're just going to say high quality CPR is the 1st
Mhm.
priority. Priority number 1 in cardiac arrest. Always, always, always high quality CPR. Now, high quality is pushing at a rate of 100 to 120 compressions per minute, minimizing interruptions to less than 10 seconds,
Right.
allowing full chest recoil where you keep your hands on their chest, but you take the weight off your hands between compressions.
Right.
All of that and we have to go down to at least 2 to 2.4 inches. All of that happens with high quality CPR. So priority number 1 in cardiac arrest is high quality CPR. What's priority number 2? Early what?
Oh, early
Okay.
defib.
Early defibrillation. So we're going to get those pads on the patient. One person is doing chest compressions. The other person is going to slap the pads on. Okay. The pads. So if here's your person, the pads typically will go in the anterolateral position. So on the right, it's upper right. On the left, it's lower left. So upper right, lower left. So you know how the ladies are talking and they're telling, one person's telling the other this juicy story, giving her all the tea. She's like, girl. So we're just going to say, girl. So that's upper right, lower left, drop the G. Okay. All right.
Okay.
So we're going to do early defibrillation. And then what's number 3?
I'm gonna go with airway. I
It's
don't
epi.
know. I'm
Epi.
kind of
All right,
confused on
so
how it asked.
that's okay. No, but what the question is, what are the top priorities in cardiac arrest? Number 1, it's early CPR. Number 2 is early defibrillation. And then number 3 is epi. Now, obviously, to give the epi, we got to have either an IV or an IO. Okay. What's our dosage of epi going to be for an adult?
1 milligram, 1 to 10,000.
Okay. And how often are we going to give it?
Every 3 to 5 minutes.
Nice. Every 3 to 5 minutes. Okay. What about for a kid? What's our epi dose going to be for the kid?
0.05, 0.03, 0.03, I
No,
believe.
not
Yeah.
for not for that epi, not for
Mhm.
cardiac arrest epi.
Okay.
You're giving me anaphylactic epi, but what about
Yeah.
cardiac arrest
Okay.
epi? It's going to be 0.01 milligram per kilogram.
0.01.
Okay.
Yep.
0.01 milligram per kilogram is our epi dose for pediatrics. Of course, you can use a Broslo tape or some kind of length-based tape, or you can use an app like Hentevi, but I'm going to just tell you, follow your local protocols. Now, how do
Right.
we convert their weight from pounds to kilograms? There's so many pounds, and we need to get them to
It's their
kilograms.
weight divided by 2.2.
Okay, so we can do their weight in pounds divided by 2.2, but I don't have my calculator in a ditch, and I need to figure out their weight really quickly. What I'm going to do is I'm going to take their weight. Everybody, turn your cameras on if you can, guys, just so I can see that you're connecting with me. Now, what we're going to do is take whatever their weight is, take their whole weight, and cut it in half. So take their weight and just cut it in half. And whatever this half is, we're going to subtract 10%. Okay. So here, let's use an example. If they weigh 100 pounds, cut it in half. What's half of 100? 50. If I
50.
subtract 50, that all I do is move the decimal one to the left. So that'd be 50 minus 5. That's going to be 45 kilograms. All right. Let's say they weigh 500 pounds. Cut it 500 pounds. Cut it in half. We got 225. Subtract. Oh, yeah. 225. We'd subtract 22.5. Okay. So, and then that's their weight.
Would it
What
not
I
be
want you,
250?
so that's just a quick.
I thought it would have been
Say that
250
again.
because half of 500 is
500
No,
and
oh, I'm
half
250.
is
sorry. Yeah, I was
250?
like, that don't look right. Yeah, that is 250. That's why it was throwing me off. Yeah. Okay. And now when we subtract, we'd subtract 25, and okay, and then what's their weight? Right.
Oh, we're doing this now? Sorry, I was listening.
No, that's okay. I was just showing you how to convert quickly. You don't have to worry about that. That's not the point of this.
Could be 225 if that's what you were saying.
Okay, yes, that would be 225. Let's just recap this. Cardiac arrest. First three
Yeah.
priorities in cardiac arrest. Number 1, high quality CPR. Number 2, early defibrillation. Number 3, early epi. For so obviously we got to use an IV or an IO. For an adult, we're going to do 1 milligram every 3 to 5 minutes. The way I like to do it is, if let's say this is our timeline, and we're going to switch rescuers every 2 minutes. So let's say this is minute 0, 2, 4, 6, 8. What I like to do is give the epi on the 4s. So for instance, we're going to give an epi here. Well, actually, let's not do it there, because that's the switch. We're going to give epi right here right at the start of the next round of compressions, and then at the 8, at the 12, at the 16. The reason that's every 4 minutes, because it flows nicely with these 2-minute cycles of CPR, because we got 2 minutes, 2 minutes, that's 4. 2 minutes, 2 minutes, that's 4. The range is 3 to 5, but if you do it like on minute 3, you're right here. You do 2 minutes of CPR and then 1 minute, and then you give the epi, and now it only circulates for 1 minute before you have to stop again. So I like to give it on the 4s. Does that make sense?
Yes.
Okay. Everybody give me a thumbs up if that makes sense. Okay. Now let's go back. All right. So let's clear some of this. So we just went into cardiac arrest management. And this is how you want your information to be, where you notice I can just bounce from one thing to one thing instantly. And that's how you want your information. The reason I'm able to do this is I've got organized information in my head, so I can always just pull up one file and go. Now, this question, what does this change most likely indicate? Well, we got to figure out what the change is. So we got a 55-year-old male in cardiac arrest. CPR is in progress. Keep going.
Initial rhythm is ventricular fibrillation.
Okay. And make sure you guys know what these rhythms look like. So VFib. All right. So they're in VFib. Okay.
And after defib and high quality CPR, end tidal CO2 rises from 12 to 28.
Okay. if we have an end-tidal CO2 rising from 12 to 28, first of all, what is a normal end-tidal CO2?
35 to 45.
A normal end-tidal is 35 to 45 millimeters of mercury. Now, in cardiac arrest, you're likely to see a really low, you're going to see kind of a low range. All right, but let's say we're down, so if down here is 0, and let's say we're at about 12, okay? But then they jump up to 28.
Mhm.
Now, is 28 normal? You told me normal is 35 to 45. Is 28 normal?
No, it's low.
Okay. So the fact that they went from 12 to 28, what does that tell me?
That they got ROSC.
Okay. Not necessarily. And so I
Okay.
put that actually as a distraction there.
Yeah. Okay.
Because ROSC means that they have return of spontaneous circulation. Another way to say that is their heart is now beating. When their heart is beating normally, we should have closer to a normal end-tidal CO2. Okay. So we would actually expect to see a number closer to 35 when like 32, something like that, when they get ROSC. We're not quite there yet, so it doesn't necessarily mean that we have ROSC. Now let's go to these answer choices.
Mhm.
So what about D?
D, equipment malfunction. I'm going to go with no.
All right. C.
I'm going to keep that just because that was my first thought.
That's okay. I like how you're thinking. All right. Let's go to B.
Effective chest compressions. I'm going to go with no,
Okay. Why?
because that has to do with the heart and blood flow.
Okay. So heart and blood flow. Oh, okay. I see where you're going. Okay. Now, so in this case, the CO2 is actually, so I see where the confusion may be in terms of ventilation.
Yeah.
In terms of oxygenation, ventilation, perfusion. And yes, it's all related. It's just sometimes there's not sometimes, there's always like a primary problem. In this situation, in cardiac arrest, the primary problem is a perfusion issue. But CO2 does help us measure perfusion. It does not measure oxygenation at all. And the only way to have a normal CO2 is to have normal perfusion. So it actually, in this case, this would be the answer. In fact, let's look at it the other way. Let's say their end-tidal was 28. So when Marshall was doing it, because Marshall, he ate his breakfast and he's doing good solid compressions. But then Lucian, he's a puny guy. He gets on.
My compressions would be effective. I'd get a 30 with my compressions.
Okay. So, all right, Tammy, we'll take you out of the box for a minute. So if suddenly the end-tidal drops, that's an indication that CPR quality is getting horrible. Okay. If it was somewhat okay, and then the end-tidal CO2 drops, that says the CPR quality is getting bad. And on the other hand, if it's low and it gets better, that says the CPR quality actually got better. So we're going to use that to actually help us determine CPR quality. So when we go back to this question, hyperventilation. So what would happen in hyperventilation? If I blow more air, what would happen to the CO2?
Go
If
up.
I blow, huh?
It would
Go ahead.
go up.
So if I hyperventilate them, I blow off more CO2. I get rid of more CO2. So what happens to my end-tidal CO2 number if I get rid of more CO2?
Drops.
It drops. And in this case, the end-tidal CO2 got better. So that's why A is wrong. Because in hyperventilation, the end-tidal I'm blowing it off. And so the CO2 would actually go down. Okay, so in this case, the answer is going to be B.
Yeah.
And the reason C is not the right answer is we would just expect it to be a little higher. Okay? We good on that?
We are.
All right, let's go with all right, so Marsh, or I guess we lost one. That's okay. You catch it in the replay. Let's go to Marshall. Let's put you in the box and let's do number 7. And then we'll stop after then. You guys good if can we do one more?
Yeah.
Okay. Let's do number 7.
What is the most appropriate approach to airway management?
Okay. 1 step or 2 step?
I think it's 2-step.
Yeah, I think this one we probably do need to read the story, so let's read it.
2-year-old child is found supine in a crib.
Stop. 2-year-old child. Are we concerned?
Yes.
The fact that we got a 2-year-old and they had to call 911, that says it's concerning already. Just the fact that it's a 2-year-old child. All right. Now, yeah, sometimes people, it's a new mom or something. She doesn't know. And so she just calls 911 because the baby coughed. Sometimes that happens, but sometimes it can be very concerning. Supine in a crib. Wait, 2-year-old supine in a crib. Is that good or bad?
Could be good.
Okay. Is a 2-year-old normally in a crib?
No.
What would a 2-year-old normally be in? Okay. So generally a crib, well, I mean, we can't really make a judgment here. It may or may not. I don't know if 2-year-olds are normally in a crib or not, but I put that kind of as a distraction. All right, let's keep going.
Parents report the child was sick with a cold.
Okay. When the patient, obviously the patient is not going to be the best source of information because they're so young, they're 2. And so they're not able to really understand things at that age. So you have to kind of trust the judgment of the parents. The parents say this child is sick. You need to believe them because they're with this kid their whole life. They know this kid every day. The mom really knows when things are going wrong. I'm not saying the dads don't, but the mom definitely knows when things are off, and you need to trust them. If mom says something's not right about my baby, you need to just trust that something's not right about this baby. All right, let's keep going.
The child is lethargic, drooling, and has inspiratory stridor.
All right, let's take them one at a time. Lethargic, is that good or bad?
Bad.
Sick or not sick?
Sick.
No, because I don't want, I mean, you're correct. I don't want a 2-year-old being lethargic. The fact that this child is lethargic, that points to what condition? What kind of situation, rather? So you know how we have oxygenation, ventilation, perfusion? And everything's about getting blood flow to the brain, right?
Perfusion.
Okay. Well, and it could be, this could be an oxygenation problem. It could be a ventilation problem. It could be a perfusion problem, but either way, I know the brain's not happy. So either way, that's a way to say they have altered mental status. Lethargic, altered mental status. Okay. Now drooling, 2-year-old drooling. Well, now when I put drooling and inspiratory stridor, by the way, stridor, is stridor an upper or airway, upper or lower airway problem?
Upper.
It is upper. And is stridor typically inspiratory or expiratory?
Inspiratory.
Yeah, and I actually said it in the question. I said they have inspiratory stridor, so I actually gave it away there. That's okay. But stridor, what is stridor? Stridor is a sound. Like wheezing is a sound. Stridor is a sound, but that happens when what's going on with the upper airway. All right. So it's a narrowing. It's a narrowing of the upper airway. Okay. So when the upper airways get narrow, that produces the sound called stridor. When the lower airways get narrow, that produces the sound called wheezing. A way to hear or way to describe wheezing is a high-pitched whistling sound. That's wheezing. That's typically a lower airway obstruction. It may be due to narrowing, or actually more often it's going to be due to an obstruction due to mucus. So wheezing is most often an obstruction problem due to mucus from within the airways. And then stridor is more of an obstruction from the outside of the airways. Okay. But stridor is upper. Now, So far, I have a drooling kid with inspiratory stridor. What immediate concern do I have? Like if I had to identify a problem of an oxygenation, ventilation, and perfusion problem now, which one of these am I going to say it is?
Oxygenation.
Stridor.
Yeah.
Stridor is an oxygenation problem because the upper airways are getting narrow, so we can't get as much oxygen in. Okay.
Mhm.
So now that I anchor this, this is an oxygenation problem. So I have a drooling kid, a 2-year-old drooling kid with stridor. What kind of condition am I probably thinking of?
Epiglottitis.
Ooh, check you out. Epiglottitis. Okay. Now, what's the other condition that's like the distraction? Croup.
Croup.
Okay. Now, how do we describe croup?
Barking cough, seal cough.
All right. So sometimes
High
it's
fever.
called a seal-like. So that's the seal-like barking. But what I want you to remember, croup is cough, a croupy cough. Epiglottitis, on the other hand, epiglottitis, I want you to think here. Let's change that to red. Let's do epiglottitis. And what I want you to think here is drooling. Okay. They describe, in this case, we have a 2-year-old that's drooling. Immediately, I want to think epiglottitis. That needs to be high on my brain. Okay. Not always. Maybe they're teething, but when they're teething, they don't have stridor. Okay. So I have a 2. Now, this is where the age matters, because what age typically is epiglottitis? 2-year-old actually would be appropriate here. So I'm thinking maybe like a 2 to 7-year-old, 2 to 6, somewhere in there is kind of more typical for epiglottitis. On the other hand, croup. So croup, we generally say it'll start at around, we see it more often 6 months to 2 years, somewhere in there. Now, obviously, what we notice here is 2 years and 2 years. So they both 2 years could be either one of them. But this is where knowing age ranges and what's most common in age ranges can kind of help you say this versus this. But in here, we got drooling, we got stridor. We need to think epiglottitis. Epiglottitis, what kind of infection is this? What kind of bug is causing an epiglottitis?
Is it viral or it's bacteria? Maybe bacteria is epiglottitis. Right.
Epiglottitis is bacteria. What's the bacteria? Which one? It could be many. The most common one used to be Haemophilus influenza type B, but it could also be strep. It could be staph. Don't worry about knowing the name of the bug, but those are just different bacteria. But epiglottitis is bacterial typically. And does it come on quickly or slowly? It produces a lot of
It's
symptoms.
gradual. Epiglottitis is gradual.
Okay. So you want to go with epiglottitis is gradual?
Yeah. I'd say it's sudden.
Okay. So typically, now, did you look that up somewhere and it said that?
No.
Tammy?
No, I'm trying to remember if it was croup that was gradual or if it was the epiglottitis.
Okay, yeah.
I couldn't remember.
So epiglottitis, we're typically going to say it's more sudden onset.
Okay.
And then for croup, we're going to say it's typically more gradual onset.
Okay.
And it's also going to be a viral infection most commonly. And the number 1 virus is going to be parainfluenza virus. Parainfluenza virus. It could be RSV. It could be lots of other things. But what I want you to know, let's recap that. Epiglottitis typically has drooling. We're looking at a 2 to 7-year-old. Bacterial infection, most common bacteria, Haemophilus influenza type B, sudden onset. Croup, on the other hand, croup has a croupy cough. So C and C, croup has cough. Typically 6 months, 2 years, somewhere in there. More gradual onset, viral infection, most common virus, parainfluenza virus. Okay. Now, also croup, the other name for croup is laryngo, tracheo, bronchitis. Laryngotracheobronchitis is the fancy name for croup. So sometimes you'll actually see them just call it that. You need to know, oh, that's the word for croup. Okay. Epiglottitis is epiglottitis. Now, the big thing here for epiglottitis is because this is a real serious life-threatening emergency. This is why you want to recognize it. We want to keep this baby as calm as possible. If, let's say, they're in the mom's or the dad or the auntie or whoever's arms, we want to keep them there, because when we go to move them, from their loved one, it agitates them, and now it causes more reactivation in the airway, makes the airway worse, and we risk closing the airway. So we need to keep this baby as calm as possible. Okay. So that's number one. We need to keep them calm, and we need to initiate rapid transport. This is a life-threatening medical emergency. You want only the most experienced person. If you had to intubate, now you're not going to try to intubate this patient. We're going to get them to the hospital urgently. This is a rapid transport, load and go, like now, do everything on the way to the hospital. Make sure you're going ahead and activating the hospital early so that they've got pediatric capabilities, maybe a pediatric intensivist or whatever to meet you in the ED. This is a serious emergency. All right. Now that I've said that, I think I gave you the answer, but let's go to number 7. Who did I have in the box? It was Marshall, right?
Yes, sir.
All right, let's put you back. Let's see if you're still there. Yep. All right, let's go. What's our answer?
C.
You're going to go with C. Okay. Now, so there's some distractions here. So administer nebulized bronchodilator. You're going to give this kid a breathing treatment. They're already stressed out. We don't want to do anything that's going to stress this kid out more and close this airway. So basically, this is just a way of saying we're going to go ahead and intubate. But there again, because when I go and put this blade in their mouth, especially if they're not deeply sedated and all of that, plus it's going to take some time. Now I risk agitating it even more. And then suctioning. Basically, all of these things are doing something to the person instead of not doing something. So this is an example of where not doing something is actually better. So we're going to put this patient in a position of comfort, keep them calm, don't agitate them. Okay.
Would this go
All
under
right,
your seed? Would you?
Ooh, okay. Check you out. Let's go. All right. You're showing off, but that's fine. No, I love it. So what's the seed? The seed is how we're going to eliminate wrong answers. What is S?
Scope.
All right. Anything that's outside of your scope. What's E?
Expensive.
Anything that's too expensive. Okay. What's A?
Advanced.
Advanced. Okay. And then what's D?
Delayed.
Okay. Now check this out. All of these answer choices, either they fall into one of these. For instance, this albuterol, okay, this is going to be a little more advanced. Okay. Now, obviously basic, well, some, depending on the state, sometimes an EMT can do a nebulizer treatment. It just depends on the state and follow your protocols there. But that's not the most basic thing. This definitely is way advanced, and it's going to take some time.
And it's expensive.
And then suctioning. Okay, and expensive, right? And then suctioning. There again, it's not. There are simpler things that we can do, but there's also it doesn't tell us that the airway is. I mean, yes, it tells us that the airway is closing, but it doesn't tell us there is. Well, it does actually tell us they're drooling. So there could still be an airway situation here, but the fact that they are drooling is actually still a good sign. Like when they lose the ability to drool, that's more concerning. The fact that they're drooling right now, just let them, they're just going to drool all over their shirt. But the main thing here is to keep them as calm as possible. All right. We're going to stop for today. I just wanted to get in that one more question. I actually have, I think I had like 25 questions. So we'll pick up the story here this evening. We'll try to get through the rest of the questions. Did you guys learn something? This,
Oh yeah.
Yes.
lipstick is getting. All right. Did you here? Let's see if I can. Let's give me some quick takeaways. Who? Let's go to. Let's see if I can get everybody at once. Just come off mute really quickly and tell me. All right. So, Lucian, what did you get today?
A better understanding of the age range for epiglottitis and croup. So epiglottitis being from 2 to 7 and croup being from 6 months to 2 years.
Okay, roughly. And those ages aren't like exact, but those are kind of general age range guidelines. Okay. And what else?
And then just refreshing my mind on the trauma triad. So the acidosis, coagulation, hypothermia.
Nice. Those are the killers in trauma. You must know that. So I'm going to probably ask you that again, probably this evening. So make sure you guys know that. All right. Caleb, what did you learn today?
Probably a better understanding of breaking the question down more.
Okay. And this is,
I mean,
all right, we're going to do a lot more of this.
Yeah.
In fact, this afternoon we'll be doing more questions, and we're also going to take like a scenario and walk through a whole scenario. We've got a couple scenario cases for this evening and questions. So to this afternoon, make sure if you're catching this in the replay, make sure that you are make sure you're watching these replays, because we've got to just keep the story moving. Okay. So what else did you learn?
Well, I mean, probably more about like the acidosis part of it, of, like the question we went over with about the burn patient or possible burn patient and the carbon monoxide and
Okay.
more of like the acidosis part of it,
Okay.
the critical part of it, I guess, like I say.
Okay. And then Marshall?
Well, Lucian took one of them I was going to say about the trauma triangle. But I really like how you break down the questions and you're teaching us a strategy of how to narrow down to the right answer instead of a possibility of a right answer.
Okay. And the other thing that there's nobody that can teach you every possible thing to know. I mean, I would need like 2 years and then I still wouldn't cover it all. The thing is, it's what's more important than me teaching you every little detail is giving you a way to think when you don't know the answer. That actually helps you more than me just cramming a whole bunch of facts in your head. I need you to have a flow. I need you to have some kind of system, some kind of pattern to use for, dang, if I don't know, okay, well, what kind of problem is this? Is this oxygenation, ventilation, or perfusion? We actually saw that today, that just by reducing it to that, just 3 things, that helps me narrow down answer choices, because it's okay. If I realize that this is a ventilation problem, but they give me a whole bunch of answer choices that deal with perfusion and one thing that deals with ventilation, well, that one thing is the answer just because it deals with that side of the triangle. Does that make sense?
Yes.
Okay. And so this is our 3rd session. We still got 5 more sessions. So if this has helped you already, can you imagine where you're going to be by the time we do another week of this?
Yeah.
Oh, yeah.
Okay.
I will say
Okay.
that
So,
the oxygenation, the ventilation, and perfusion thing, I had 2 calls the other night in the middle of the night where you're not really thinking properly, that the oxygenation, ventilation, perfusion thing had already was like, oh, wait a minute, let me just go through this. And I was looking at that because I had a bad COPD call, and then I had an altered mental status, somebody who took an extra day's worth of meds, and we didn't know what was going on, but initial presentation was lethargic. So initially, once we saw that, I was like, okay, sick. And like just going through that in my head, even though I wasn't the paramedic on scene, like I was watching and thinking of those things, already using
wow.
it.
And so was that, hold on. I gotta spotlight this, man. Hold on. Like this is too good. Let's hold on. Let's put you in the box. All right, say that again, because that was so good. I need to use this later.
Yeah, the other night I had 2 calls, and one of them was a bad COPD call. So initially, when it came out, patient was short of breath, on oxygen at home with productive cough.
Mhm.
And so just showing up initially with the way that the patient was presenting, she was a little bit altered. So initially I was like, okay, well, oxygen, glucose, and whatnot, like going through my oxygenation, ventilation, perfusion issues.
Okay.
And then we ended up going from a nasal cannula to a non-rebreather to CPAP and with the inline nebulizer. And you could see the improvements just based off of me thinking oxygenation, give them oxygen. We gave her oxygen and she had already improved, just
Wow.
not altered and
And
whatnot.
so, yeah, we narrowed it down to, in this case, you narrowed it down to
And
it was
then,
an oxygenation problem.
right. And then the call
And
after
all of
that.
those things that you mentioned are all ways that we improve oxygenation.
Right.
Okay.
And then the call after that at like 5 a.m. was an altered mental status, and she was lethargic, not super responsive. And so we didn't necessarily know what was going on. Her pupils weren't necessarily pinpoint. And so we initially, like, the medic was still trying to like figure out what was going on. And in my head, I was running through, okay, oxygenation, ventilation, perfusion. She's altered mental status, so sick, not sick. Gave her, we started off with a nasal cannula for her too, saw a little bit of improvement, went up to a non-rebreather with her. And then once we gave her a non-rebreather, brought her sats up to like 95. And instantly you could already see her starting to come back more just from oxygen.
And then one of the things that you definitely want to be doing with these respiratory patients is go ahead and use, whether you're using a just capnography through a nasal cannula,
Right.
or if you use the regular capno nasal cannula and put a non-rebreather on top of that. But all of these respiratory patients, you want to be using end-tidal CO2. Any patient in shock, you want to be using end-tidal CO2 because yes, CO2. So I have it on the ventilation side, but CO2 itself is actually a very good indication of perfusion status. Okay. So any
And that
patient
was,
with any kind of perfusion issue, CO2 would be, or we need to monitor CO2. So every shock patient, every major trauma patient, every respiratory patient, every cardiac patient, you should be using, you want to be using capnography. Like if I had to throw away the pulse ox, but they give me capnography, I'm going to go with capnography all day, every day.
that was
Okay.
another thing that was also her vital signs on the altered mental status. Initially was like 74 over, I don't remember. It was 74 over bad is what it was. And so I was like, well, that's not good. Her heart rate was, I want to say it was like 120. So it was like these signs and symptoms of shock that you talk about. So I was like going through, okay, keep them calm, keep them warm, heart rate, respiratory rate. Then you go to fluids. So then we went to fluids and our heart rate started, or everything started to kind of even out after the just fluids and oxygen. And so just going through like the checklists and whatnot.
Okay, this is cool. And check this out. Like you're still in training with me, but just in training, you haven't even passed the test yet. But just in training, you're already able to take this information and apply it in a real patient. I mean, is that not cool? Because remember, I tell you guys that I'm not just here to help you pass a test. I'm here to not only help you pass, I mean, obviously you got to pass the test, but I want you to be a great clinician once you pass the test. The test represents one day of your life. If you take it more than once, it's still like if you add up all the time that you're going to test, it's still like less than a day. Compared to all the days that you're going to run calls, what do you need to be more prepared for? One day of your life or a whole career? You need to be prepared, obviously, for a whole career. I'm helping you not only pass the test, I'm helping you learn to think like a clinician. Okay. All right. So good. Way to go. keep growing, keep learning. We never stop learning. We're going to go ahead and end it, guys. I apologize. We went a little over. We were just kind of getting some takeaways. So watch the replays. The replays will go up. By the way, you guys tell me, did anybody watch the replays from Tuesday?
Yes.
I haven't yet, but I'm going to today.
Okay, so I want to ask this question. So like right now, I'm here in the studio and I'm recording in the studio. what I've noticed though is like the file from the other day ended up being like 25 gigs. And so when we're having to upload it to the cloud, bring it back down from the cloud, it's taken like 10 hours for the processing. I'm also recording it in Zoom. The Zoom, what it does is it compresses it though. So the video that I played the other day, were you able to see it clearly?
Yeah, I watched it. I went through the website or the portal,
Yeah.
and I watched it
Yeah.
I watched the morning session, the whole thing through there, and it was all perfectly fine.
What device? On a laptop or a phone?
On my iPad.
Okay. So a tablet. So, because I'm in the studio, I'm actually streaming in 4K, but Zoom compresses it to like 1080p or 720, and so sometimes the quality goes down. But I want to make sure that you're at least able to see everything that's popping up on the screen. I may have to just use the Zoom recording just so I can get it up faster, because otherwise it took like 10 hours the other day on one video. So, all right. That's it for me. We will see everybody back tonight. All right, you'll get the email. Make sure you're back. We'll start. The Zoom window will open probably about 10 minutes ahead of time, and then tonight we're going to hit it hard with with more questions, and we're also going to do at least one scenario. So, any final questions?
No, sir.
No.
All right, good job, Marshall. You're. I'm seeing the smile more. And seriously, and even with Caleb, I noticed a difference from the first session to the second session. So, are you feeling like your confidence is improving?
Yes, sir.
Okay. And what is it that makes what makes you notice that you're improving?
I just feel like, how you're teaching the strategy is clicking, and now I'm seeing the light at the end of the tunnel, if that makes sense. I'm starting to see where I was making mistakes and making a choice that was wrong on a question.
Wow. Honestly, as you just said that, I felt it. Like I feel that. So no, honestly, I appreciate it. And thank you so much. You're doing an amazing job. I want you to just lock in with me. Make sure, especially over this weekend, since there's going to be a few more days until our next session after tonight, because we'll do Thursday night and then we don't come back together until Tuesday morning. So over this weekend, even though it's a game and all that, I really want you to lock in, make sure you're going through those videos so that you can, I guess I should be looking at the camera, but I'm looking at you on my
You're
monitor.
good. You're good.
Okay. So, but I want you to really lock in so that you can, all these concepts that we're teaching, you've got to keep, you got to keep anchoring them in your head, because we're just going to keep building on that. As we keep doing more scenarios and drills, obviously we're going to get a lot more reps in. We're going to do a lot more practice. Okay. That's it, guys. I have nothing further for now. I'll see everybody back tonight.
Appreciate it.
All right. See you tonight.
Thank you.